Hello, so welcome back to a Balance My Hormones video. We are here with Dr. Sanjay Gupta, who is he's a pretty famous cardiologist. He's got a great YouTube channel, really good information on there, explained really well. The way he puts it across, I think most people can watch that and get really good information from it. So if you'd like to find out more about that, keep watching. We are here with Dr. Sanjay Gupta, who is he's a pretty famous cardiologist. So he is based out of York. The channel is called York Cardiology. So thank you for coming on.
Thank you for having me. And the whole idea is to make people aware, because the reality is we're not going to have a big randomized placebo-controlled trial anytime soon. And when we do, there'll be a bunch of people who will sit there and say, oh, we need more data, or they'll pick holes in the data. And so the poor guy, the poor person who's just a little bit unhappy with his overall health, he's never going to know about any of this.
Yeah.
And so to educate people is a good thing, because they can then A, become informed, B, look out for data, C, contact people like yourselves who have experience with this kind of thing.
The endocrinologists, it seems like it's endemic in that profession, in that they really frustrate and anger some of our patients. So you hear stories of them just torturing the patients in some ways. I mean, say, oh no, you're fine, leave it alone, putting them on antidepressants and things like this. And so they're so willing to put them on artificial antidepressant, but not the bioidentical hormone their own body makes. I don't understand why that's somehow safer.
Even stories of like guys who've lost a testicle or had testicular torsion and all these things, and have very low testosterone and actually meet like even some of the sexual medicine guidelines, are refused. Like guys that refused for 6 years of low testosterone, crippling depression, anxiety, sexual dysfunction, Viagra and citalopram was the answer. You're not a candidate for TRT. And it's like all those things for me, which is like, surely that ticks a box somewhere, trauma and it seems to be a bit of an issue. But like, I used to work in the NHS, and we train, as a physiotherapist, like in orthopedics and trauma and the musculoskeletal side, we learn within the boundaries of what that place offers, right, as well. So we are influenced by that as well, and we can offer that, so you won't get training in that to utilize it in practice.
I don't think you're trained in critical thinking. We're not allowed to think like that. Anything like that is, in some ways, it is okay. And most researchers has a vested interest at the back of it anyway. So it's all a money-making machine. Medicine, healthcare is very disease is very profitable. Health is not profitable. Disease is very profitable.
Yeah, that's so true.
And that's always this little tinge of a conspiracy theory behind why men can't get their testosterone. It's the big drug companies would rather sell these other molecules rather than you go on a cheap testosterone. And I suppose we say it so much and hear it so much, it's probably true to a certain extent. And the regulators don't help. They all are part of the same side.
Oh, absolutely. Absolutely.
So anyway, hopefully the information gets out and our channel doesn't get shut down or a company gets shut down.
Oh, I don't think so. I think it's if the information is presented in the way whereby it's honest, and you're not trying to say, oh, do this or do that. You're just saying this is what we know, and you're allowed to ask questions about it.
Yeah, that's fair. At least you got some free speech still. Next one on thyroid. It's changed my life, thyroid.
Yeah.
And Sam's as well. We were. Testosterone got us to a point, but I looked at some old pictures of me, how bloaty and the myxedema and the lack of.
We've both got Hashimoto's, haven't we? That's what we didn't know.
It's and there's all the autoimmune. It's all kind of tied together. So testosterone's the start, but thyroid kind of polishes it off. It's interesting. That's why I would not just balance my testosterone, even though I own that site.
It's very interesting. I think there's this underlying process that goes on, and I suspect stress and inflammation contributes. And every organ system, if you think about it, the pancreas suffers, the heart suffers, the brain suffers with dementia and all that kind of stuff. The liver suffers with fatty liver. We see it all the time. We see the kidneys start suffering. Now, the current creatinine measurements is they're only looking for you've lost your one kidney by the time your creatinine starts going up, really.
Yeah.
So to my mind, when you think about it, the body is, it's one big machine, isn't it? And one side of it affects the other, and it's very interesting. And we have to start thinking holistically. We have to start thinking of all those things. Ideally, I would like every single patient. So I was very interested. I was saying to my patients, I was in a meeting one day, and they said, "Oh, diabetes can cause heart disease." And I said, "What about heart disease causing diabetes?" Meaning that, yes, when someone comes in with a heart attack, you say, "Oh, are they diabetic?" No, they're not. But how many times do you follow people who've had a heart attack and go and look to see whether they develop diabetes? And I bet you'll find a much higher incidence of diabetic patients becoming diabetic after their heart attack.
Or they have the pre-diabetes, like you said, all along.
Exactly. Just because that is precisely it. That is precisely it. I think it's really interesting. You should definitely look into the SGLT2 inhibitors, which are going to revolutionize. Now, this is a medication which has been around for 5 years, proven in a really big randomized placebo-controlled study, ticks all the boxes. Empagliflozin in patients who have any kind of vascular thing, you give it to them, they live longer.
Any major side effects, or is it more
Not
like
really,
metformin?
Not really.
How does it compare to metformin? Because you kind of made you alluded to the fact that they were on the metformin, changed the numbers, but didn't change the outcome. So what is it? Yeah.
I mean, it does change the outcomes in the sense that if you have lots of blood sugar wandering around, then that blood sugar will cause more harm. So that makes sense, that lower the blood sugar. But it doesn't tackle the thing as to why the blood sugar went up in the first place. And if that is a much more kind of generalized indolent process which is harming the body, then maybe treatments that aim at tackling that will do both. Tackle the underlying process and improve the damage done by the symptom of the process, which is the high blood sugar. This is exactly the same with high blood pressure, isn't it? That yes, we worry about blood pressure. Why? We worry about it because we're worried it'll cause heart attacks and strokes. And so everyone says, treat the blood pressure, you reduce heart attacks and strokes. But one, treating the blood pressure you can treat it with an ACE inhibitor, you can treat it with a beta blocker. You can reduce the blood pressure to the same amount, but the outcomes are different. Suggesting that it's not just about reducing the number. One type of medication may have something else, some other effect over and above reducing the number, which seems to improve outcomes. So, and the second thing is, if your high blood pressure has been caused by sleep apnea, then making the number better and not tackling the sleep apnea is missing a trick, and a big one.
That's great. That's great.
We both have sleep apnea.
It's like trying to get
we're like brothers of a different mother.
Well, this is exactly it. Chronic disease. Everyone's got sleep apnea. Everyone's got disrupted hormones. Everyone's all these things. Everyone's got fatty livers. So I'm sure.
How do you measure for fatty liver? I mean, we can sometimes guess from high SHBG levels that there may be a fatty liver, but what other measurements do you use to determine fatty liver other than a scan? Do you do ultrasound or MRI?
Again, I think the reality is that who's got a fatty liver, because when they walk in, they're generally middle-aged, they're generally trunkily obese. They'll say, I've got diabetes or high blood pressure. If you look hard enough, you'll find kidney disease. It's just no one looks high enough. They wait for the creatinine to go up. They all have underlying sleep apnea. In patients with atrial fibrillation, 1 in 2 people have sleep apnea. 1 in 5 people in the population have sleep apnea now. 85% of sleep apnea is undiagnosed.
That's crazy.
You have sleep apnea, it affects your thyroid, it affects your testosterone.
Yeah.
And testosterone sometimes unmask the sleep apnea.
Exactly.
And to make it so obvious, because it seems like with the poor NHS, unless it slaps some square across the face, they don't even know what you've got.
No.
It has to be so textbook, for them. Then they'll be, oh yeah, we'll treat it now.
I had to. I've got sleep apnea. I think I've got a weird neck and jaw, probably. Great genetics, but I I figured out before, obviously speaking to GP friends and stuff, sort of what the scores were that you have to score on the questionnaire just to get a referral. And I was falling asleep when I was reading a book, when I was driving a car. Like I was highly likely to fall asleep doing all of those things to score. And then I got there and they're like, yeah, you've got sleep apnea. It's the outcome measures, right? It's like, it is these things that
This is why I think what I've done is I've produced leaflets for patients. I've given them the scores to measure. Because they may go to a GP and they may see a clinical assistant. Who knows? Who knows who you're seeing now? When you go and see a doctor, what is this GP? What is this? Who is this doctor? Just because they've got a name doctor, you know, what does that mean? They've got now the NHS is about training, you know, nurses to become advanced healthcare practitioners, right? So I've seen an advanced healthcare practitioner. The problem with this thing is that you are taking a person, you are not teaching them to think critically. You're saying, this is what you do, this is what you do. And nurses are very good at following that. So when a 95-year-old comes with a heart attack, he'll get put on statins and aspirin and clopidogrel and God knows what else. And you've got this and you've got that. And no one has the common sense to ask, well, why am I giving it? I'm giving it because I'm going to make him live longer. So the next question is, well, how long do people live? Generally, the life expectancy in this country is 81, 82 years. The guy at 95 has already won the race by 15 years. You are not going to make him live longer by giving him a statin. But you will make him miserable.
I was going to say it could compromise other lifestyle.
Yeah, of course, you'll make him miserable. You know, how at 95, do I want to be given a bucket load of pills today? The only thing I want is for someone to come and ask me nicely, how do you feel today? And if I feel good, that's a blessing. And if I feel bad and I've got pain, then yes, give me something to take me, you know, improve my symptoms. But we shouldn't, and this kind of thinking, this kind of just simple common sense, the courage that is required these days to think outside is incredible. You know, the courage you have to demonstrate to ask questions like this is unbelievable. I was at Harvard as a research fellow. And I was appointed, and I remember before going to Harvard, I was like with my wife, and I said, "Oh my God, this is one of the biggest names in the world. This hospital, this center, this guy's got 30 of the best people from around the world working for him for free, because they deem it such an honor to work with this guy. I don't know how I'm going to function. How am I going to work? How am I going to manage with people like that? You know, I'm not something special." And anyway, I went in there, and my first research meeting, this guy turns up and he's got his computer, and 30 researchers are working away on the computers, and he's barking out orders. And what does this show? And what does this show? And they're all like, it shows this, it shows this. And I was like, I don't know what this is all about. Let me ask the question that came into my head, which was, I simply said, I'm really sorry for this, but could you tell me what your research question is? Because you're doing all this analysis and I don't know what you're asking, so I can't contribute, so please tell. And they all looked at me absolutely horrified. And they said, what do you mean, what is the question? There is no question. The question comes later.
What?
We're going to analyze data. We're going to find a correlation. We're then going to build a question around the correlation we've found.
Wow.
Right.
And this is how research is done.
Yeah, that's backwards.
And this is at Harvard Medical School. So to my mind, you know, I have the more degrees a person has, the more devoid they are of common sense. The problem here is a productive doctor is a doctor who will get as many people in and out of the door in the shortest period of time. That is the definition of a productive doctor.
Yeah.
No one looks at the outcome measure. No one says, well, were those patients satisfied with, and this is how it's practiced. Training has been curtailed. Doctors are now being produced earlier. Consultants are made consultants at a much earlier stage.
Mm.
And a lot of their grading is based on tick boxing. Did you see 3 of these? Did you fill in 5 dots where someone observed you do this? That, to my mind, is not, you don't train a doctor. And there's more to, the job that we're doing at the moment, a monkey can do.
Well, the way they force you guys in the
Because you can have a tick boxing thing. You can say, okay, you've got diabetes. No one's going to say on what basis. You've got high blood pressure. Oh, you're on a blood pressure tablet. No one's going to say, well, was that even warranted?
Yeah.
But now you see, as soon as you've got a blood pressure diagnosis, the insurance companies make money out of you. The blood pressure tablet medication makes money out of you. The GP gets a nice little earning from whoever, the CCG or whatever, for diagnosing hypertension.
Yeah.
The pharmaceutical company make a lifetime of money out of you.
Mm-hmm.
And the reality is, after all this, you have been sold the idea that this is good for you, and you will never know. That's the most incredible thing. The most incredible thing is, if I come to you today and I say, buy this pill because it will make you live longer, the first thing you'd want to know is, what's the evidence it'll make me live longer? No GP will be able to give you numbers needed to treat for giving you a pill. Because anything that is good for you, if true science is being practiced, anything that is good for you will be based around a number. Because all science is about controlling and measuring, isn't it? You control something, you measure it, and then you decide whether it's good. Well, that measurement is the number.
Yeah.
Right? And the number is the number. The number is the number. No professor knows the number better than, he doesn't know a different number. The number is the number. If a study has been shown the statins are beneficial, what is the number? You will struggle to find anyone who knows the number. And the reality is, as patients, we should know the number. We would do that if we were going away on, if we were getting life insurance, we'd want to know how much we were going to be paid. If something bad happened to you, we'd want to know. Yet we're here taking a medication for the rest of our lives, and we will never know.
That's crazy. I think you said something really good, like in terms of lifestyle advice, like if you're looking for evidence of it, we sort of roughly know what is good for us and what is bad for us, and you just sort of make sure you don't do too much of the stuff that's bad for you, while still dabbling in that if it makes your quality of life better, and you try and do that, as many good things as you can without compromising your life in that way as well. And
modern day medicine is about patient enslavement. Modern day medicine is enslaving the patient. You don't do this, don't do that. Oh, that's bad for you. Oh, that's bad for you. I believe good medicine is about liberating the patient. I believe that the patient should be told, hang on, your life, your choices. My job is to give you the information you want in a language you can understand, and to facilitate that which works for you.
That's the way it should be.
In fact, I had a guy, one of my stroke physicians came back, and he came to me the other day and he said, look, I need to have words with you. And I said, yeah, why? And he said, well, you said in a video that atrial fibrillation doesn't cause strokes. And it is associated with strokes and doesn't cause strokes. And I said, yeah, I said that. Well, you can't say stuff like that. And I said, can you prove it otherwise? And then he said, no, you're right, but you can't say stuff like that. And I said, well, why can't I say stuff like that? Well, people won't understand. I said, well, that's that's for them to decide. I've not said anything. I've just given them data.
Given the info.
I've given them data. But it's crazy, isn't it? When people just turn around, and sensible doctors turn around and say, well, you can't. And there's no good reason why you can't, but you can't.
Yeah.
There's like this whole thing with medicine in the UK in general. It's no basic rule of law applies. Things that like freedom of speech or the right to a trial and not be judged guilty or be told you're guilty until proven innocent. If they turn in all the legal basis on its head, for doctors here. I think there's a real hunger for patients to have this information, a huge hunger, because they're not getting it.
Absolutely, absolutely. I would love for the channel to grow bigger. I would love for that, to become like an NHS place, but you're getting more carefully dissected information.
Yeah, you're definitely achieving that already, 100%.
I mean, we see it on our front, on the TRT side. It's kind of the basis for so many people. And we're saying, well, look, you don't have to worry if you don't have insurance, or if we're not part of the NHS. We try to make it affordable, sustainable for people, and I think we do a nice job of kind of opening up that access where they wouldn't have had it before. So, what do you think, Sam?
Yeah, and just the education just about hormones, and it is literally just explaining in a way that, like I spoke to a chap today that was just like, well, just thanks for doing that on the YouTube channel, because actually there's a lot of things that actually you say that others have explained with a load of waffle, and you just sort of bring it down to simplifying it just so that you can feel, if you're a patient before considering hormone therapy, that you can make an informed decision, right? It's not like you need to do this, you must do that. If your levels are low, you've got to do that. It's all very much about these are the risks, these are the things that people can see, these are the expectations. There are people that it doesn't help, it might be something else, and people, like you say, it's exactly that. You're giving them the information, and then they do what they want to do with it, but you've given them the information and not advice, right?
Exactly. That I think is the crucial thing, because information is everywhere. They can't, information is, you switch on TV, information is there.
Yeah.
And they can't criticize me for giving information.
Absolutely. I think that's how we'll change things. Okay, so thank you, Dr. Gupta, for joining us today. I hope the viewers, found that helpful. If you would like to listen to more information and get more information about this, please subscribe. Ring the notification bell, because you'll get notified of more content like this. And thanks for joining us. So we'll see you next time.
Okay, see you next time. Thanks.